thank you for inviting me to speak at this 32nd annual scientific session of the Sri Lanka College of Microbiologists. As you have already said, I'm Samita Majumdar. I'm the consultant microbiologist at the University Hospital, Coventry. I've been asked to speak on the role of multidisciplinary team in antimicrobial stewardship. So we all know the background that antibiotic development since 1940 has been critical in the management of infections. But in the 21st century, we are facing different problems, naming increasing antimicrobial resistance due to inappropriate use of antibiotics in both human and animal health, increase in difficult to treat infections, and slowed development of new antibiotics. WHO has announced a global action plan in 2015, and this has recognized antimicrobial resistance as a global threat to public health, causing about 70,000 global deaths per year and estimated to rise to 10 million by 2050. So we can see the enormous problem. Coming to antimicrobial stewardship program, historically, many programs started as a grassroots level from pharmacy, but truly effective programs will need to involve professionals outside of the pharmacy department. Various studies have shown that the positive impact of antimicrobial stewardship MDT approach, escalating interventions, cause different improvements. So this is the CDC guideline published in 2019. They have given us 7 core elements of hospital antibiotic stewardship program. Of these, the first 3, hospital leadership commitment, accountability, pharmacy expertise, these illustrate the multidisciplinary team antimicrobial stewardship. So coming to the first one, hospital leadership commitment. So support from senior leadership, that means like chief medical officer, chief nursing officer, director in pharmacy. This is critical for the success of AMS program. And they have advised that hospital leaders need to ensure engagement from other key support groups and departments, namely clinicians for their prudent use of antibiotic, departmental program heads for their support to resources for time, money, and personnel, pharmacy and therapeutic committee for their key role to develop and implement policies, infection preventionist and hospital epidemiologist to offer education to all staffs and to report and analyze data on antimicrobial resistance and quality improvement, patient safety, and regulatory staff for advocating adequate resources and to integrate interventions and quality improvement efforts. Microbiology lab to guide the proper use of test and flow of results. It has got another name like diagnostic stewardship. And to help optimal use of antibiotic, to implement rapid diagnostic tests, and to develop guidelines for the clinician. Information technology to ensure relevant protocols are available to the point of care, to implement clinical decision support for antibiotic use, and to facilitate reports for local and national surveillance. Last but not the least, nurses. They can optimize testing done before antibiotic is started. They can review prescribing, and also they can evaluate proper penicillin allergy history, as choosing of the right antibiotic depends a lot on that history as well. Now, coming to accountability, designated leader or co-leaders should be accountable for the program management and outcome. And most hospitals have found that a co-leadership model is very effective. There was a survey in 2019 in USA, and they showed 59% of the hospitals have a stewardship program that were co-led by physician and pharmacist. Programs that had co-leaders should have a clear delineation of responsibilities and what is expected of them. Larger facilities have achieved success by hiring full-time staff to develop and manage stewardship programs. The next one is pharmacy expertise, or it is also called drug expertise. Strong engagement from pharmacists, either as a leader or co-leader of the AMS program, is essential. Infectious disease trained pharmacists are highly effective to lead implementation of prudent antibiotic use, but even the general clinical pharmacist with specific training and or experience in antibiotic stewardship can be very effective as well. Now coming to the last 4 action points, and these are the methods the team needs to implement for interventions. So action. What sort of actions antimicrobial stewardship team needs to deliver for proper stewardship? So they advised on prospective audit and feedback, which is also called as post-prescription review, and pre-authorization of antibiotics. These are 2 most effective stewardship interventions in hospitals. Facility-specific treatment guidelines. These are also very helpful because these can enhance the above 2 methods by establishing clear recommendation for optimum antibiotic use. Among different other actions, common infection-based interventions, for example, community-acquired pneumonia, UTI, skin and soft tissue infection, or other infection-based interventions like sepsis management or C. diff management, provider-based interventions like antibiotic timeouts, that is um, um, review of antibiotics after 48 to 72 hours, and microbiology-based interventions like specific antibiotic reporting. We should not report all sensitivity, and offering appropriate comments to decide for the clinician which organism is significant or pathogenic, because not all organisms we grow are pathogenic. And last but not the least is nursing-based interventions. So they can promote IV to oral transition therapy, prompting antibiotic review by doctors, and optimizing the microbiology culture before antibiotic is started. Next is tracking. Tracking to do the monitoring of antibiotic prescribing, to look at the impact of the interventions taken, and other outcome measures, as I mentioned earlier, CDT infections, and what is the resistance pattern. Reporting of regular updates on antibiotic use and its resistance to prescribers, pharmacists, nurses, and hospital leadership. These are important aspects of antimicrobial stewardship program. And education is, of course, key component of comprehensive efforts to improve antimicrobial use. We need to educate prescribers, pharmacists, nurses, patients also about adverse reactions, antibiotic resistance, and optimal prescribing. So the jointcommission.org produced some standard, and in that they have stressed on organizational priority through support of its antibiotic stewardship program, and also the must on allocated financial resources for staffing and information technology to support AMS program. They have also advised on developing champions across department like pharmacy, medical staff, infection control, quality, and performance improvement, and also nursing services. So the Joint Commission has some objectives, and they have presented in agenda form. So there are different agendas, and they have advised on who should be the responsible party and at what frequency they should review. In UK, we have NICE guideline on antibiotic stewardship, and very similarly, they have also advised on core membership of AMS, which should be antimicrobial pharmacist, medical microbiologist, and additional members depending on which care setting we are. So, for example, hospital or primary care, etc. NICE also has advised that we should encourage and support prescribers for appropriate prescribing. We should encourage health and social care practitioners across all care settings. We need to develop a system for peer review prescribing for a good practice maintenance, and senior health professionals to promote antibiotic stewardship within their teams because they can work like a role model, and ensure that lab testing for susceptibility to antimicrobials is reported in line with antimicrobial stewardship program. IDSA and Society for Healthcare and Epidemiology of America, SHIA, they have also produced guidelines. I've just given you the link here, implementing an annual stewardship program. This is also a very important source of information. So I'll now discuss about few studies where they have shown how multidisciplinary team approach has helped. So this first one is an impact of multidisciplinary team escalating approach on antibiotic stewardship in United Arab Emirates. So they had adopted 12 different types of interventions, and they have two groups, non-intervention group and intervention group. So the results from the intervention group shows that they have achieved successful improvement in patients' clinical outcomes in the medical wards in relation to their length of hospital stay, readmission, and mortality. They have also showed that they could decrease daily defined dose of antibiotic adjusted per 100 patient days. And these are the antibiotics that belong to WHO aware categorization. I've got these stars because I put a slide of what is that categorization in the next slide. Also, the results showed improved outcome in IV to oral antibiotic ratio and highlighted the impact of clinical pharmacists that can deploy in a stewardship era. So this is the WHO aware group essential antibiotics. I'm sure you all are aware of, but I just put it for your information. Now, the second study is on impact of multidisciplinary stewardship team intervention, focusing on carbapenem de-escalation. So this team used post-prescription review and feedback to look at the optimized carbapenem use. They arranged every week conference on patients who are receiving anticarbapenems, They encourage one prescriber to comprehensively engage in examination, selection of antibiotic, its proper dose, frequency, when it should be discontinued, how long it should be given. And then antibiotic stewardship team provided recommendation to that attending physician. The antibiotic stewardship team consisted of physicians, pharmacists, infection control nurse, and microbiology technologists. And they also collaborated with ward-based clinical pharmacists when necessary. And the study shows that the MDT strategy has enhanced the carbapenem stewardship on a clear definition that how they can de-escalate the carbapenem use. A third study here is on evaluation of multidisciplinary antimicrobial stewardship program in Saudi critical care unit. And this one, they showed that involvement of higher administration in multidisciplinary team. They have done daily audit and fed it back to the clinical pharmacists and physicians. They offered continuous educational activities on antimicrobial use and resistance. And they used local antimicrobial prescribing guidelines based on up-to-date antibiogram and support from the intensive care unit. And again, this MDT approach showed the optimized antibiotic use in Saudi healthcare institutions. This one is a study on impact of multidisciplinary team on timeliness of antibiotic after positive blood culture. It's a randomized controlled trial, and I've given you link if you want to read the full trial. And again, this trial has shown improved time to both active and appropriate therapy. And majority of the patients where blood cultures was a contaminant was not started on antimicrobial therapy. And as microbiologists, we all know how important it is that we do not treat for contaminants. So antibiotic stewardship program provides a practical and a manageable approach to use of antibiotics within our healthcare system, which aims to reduce antibiotic resistance and prolong their ability to continue fighting against infection. But ultimate success of stewardship depends on multidisciplinary team working with education and feedback. So this is a WHO toolkit for an example of MDT AMS governance structure. And as you can see, in the center, it is the AMS committee made of AMS team and healthcare facility leadership. And then on the sides, different departments which would have to be part of the AMS team to offer a good antimicrobial stewardship in the hospital. So I'll end saying this quote of Henry Ford, that teamwork, coming together is a beginning, keeping together is progress, and working together is a success. Thank you.